Welcome to a visual algorithmic toolkit built specifically for high-yield clinical pattern recognition, investigation synthesis, and board examination mastery in respiratory medicine. 5 core diagnostic numbers anchor this entire system, and mastering them transforms an overwhelming subject into a structured, predictable framework. A PaO2 below 60 millimeters of mercury defines the hypoxemia threshold, the foundation of respiratory failure classification. An FEV1 to FVC ratio below 0.7 defines an obstructive pattern on spirometry. A pleural fluid to serum LDH ratio above 0.6 serves as a key pleural effusion marker within Light's criteria. The alveolar arterial gradient tells you the oxygenation status of the lung itself, distinguishing intrapulmonary from extrapulmonary disease. And a reduced DLCO indicates diffusion impairment across the alveolo-capillary membrane. Across USMLE, MRCP, PLAB, AMC, and MBBS examinations, these 5 numbers recur constantly, embedded within vignette after vignette. This video will walk through each one systematically, building toward integrated diagnostic algorithms for the solitary pulmonary nodule, suspected pulmonary embolism, and interstitial lung disease, transforming isolated facts into one coherent diagnostic dashboard you can apply to almost any respiratory case. Arterial blood gas analysis begins with classifying respiratory failure into 2 fundamentally different types. Type 1, or hypoxemic respiratory failure, shows a PaO2 below 60 millimeters of mercury with a normal or low PaCO2, reflecting primary gas exchange failure. Classic causes include pneumonia, ARDS, and pulmonary embolism, where the problem lies specifically in oxygen transfer rather than ventilation. Type 2, or hypercapnic respiratory failure, shows the same low PaO2 below 60, but critically combined with an elevated PaCO2 above 50 millimeters of mercury, reflecting alveolar hypoventilation. Classic causes include COPD, severe asthma, opioid overdose, and neuromuscular disease, where the fundamental problem is inadequate ventilation rather than gas exchange itself. Beyond classifying failure type, the compensation scale tells you about timing. Acute respiratory acidosis develops within minutes before the kidneys have time to respond, so elevated PaCO2 combined with a normal bicarbonate indicates an acute process. Renal metabolic compensation, by contrast, takes days to develop, so elevated PaCO2 combined with an elevated bicarbonate indicates a chronic, established process. A critical timing distinction that lets you separate an acute exacerbation from long-standing compensated disease using nothing more than a single blood gas result. When evaluating any hypoxemic patient, calculating the alveolar arterial gradient is the single most powerful next step because it immediately splits the differential diagnosis into 2 completely separate categories. A normal A to A gradient points toward extrapulmonary causes, meaning the lungs themselves are structurally healthy, but something outside the lung is preventing adequate ventilation. Classic causes in this category include central hypoventilation from opioid overdose, neuromuscular weakness preventing adequate chest wall movement, and high altitude, where the lungs remain entirely normal, but ambient oxygen is simply reduced. An elevated A to A gradient, by contrast, points toward intrapulmonary causes, meaning the lung parenchyma or vasculature itself is diseased. This category includes 3 distinct mechanisms: ventilation-perfusion mismatch, where some areas of lung are ventilated but not perfused, or vice versa; right-to-left shunting, where deoxygenated blood bypasses ventilated alveoli entirely; and diffusion limitation, where the alveolar capillary membrane itself is too thickened or damaged for efficient gas exchange. This single calculation, performed in seconds at the bedside, can immediately redirect your diagnostic workup away from unnecessary chest imaging and towards central nervous system or neuromuscular causes when the gradient is normal. Pulmonary function testing provides the essential mechanical framework for distinguishing the 3 major categories of lung disease, and a single comparative table resolves nearly every related exam question. Asthma and COPD both show an obstructive FEV1 to FVC ratio below 0.7, but they are sharply distinguished by reversibility testing. Asthma shows a positive reversibility response, with FEV1 improving by at least 12% and at least 200 milliliters after bronchodilator administration, while COPD obstruction is largely fixed and irreversible. Restrictive disease, whether from pulmonary fibrosis or chest wall pathology, shows a preserved or even increased FEV1 to FVC ratio, since both values fall proportionally together. The third critical differentiator is total lung capacity and residual volume. Asthma shows increased values due to air trapping during exacerbations. COPD shows increased values due to chronic hyperinflation from chronic destroyed elastic recoil. Restrictive disease, in sharp contrast, shows a reduced total lung capacity, and this single finding provides the definitive confirmation of a true restrictive pattern, since spirometry alone can sometimes appear ambiguous without this additional lung volume measurement. Flow volume loops translate the same physiological information into a distinctive visual shape, and recognizing these shapes instantly is an extremely high-yield image-based examination skill. Obstructive disease produces a characteristic scooped-out, concave expiratory limb caused by dynamic airway collapse during forced expiration. The airways themselves narrow excessively as the patient tries to exhale forcefully, creating this distinctive concave dip. Restrictive disease produces what is often called a witch's hat profile, a symmetrical loop that is narrowed overall due to reduced total lung volume, but critically retains its normal shape rather than becoming concave. Fixed upper airway obstruction, such as tracheal stenosis, produces a strikingly different, box-like appearance, with flattening of both the inspiratory and the expiratory limbs simultaneously, a key distinguishing feature from variable obstruction, where only one limb typically flattens, depending on whether the obstruction is intrathoracic or extrathoracic. Training your eye to instantly recognize these three distinct loop shapes, scooped, witch's hat, and box-like, allows rapid pattern-based diagnosis directly from a single graph, without needing to calculate a single ratio. DLCO measures the rate of carbon monoxide uptake across the alveolar capillary membrane, serving as the definitive functional test of gas exchange efficiency, and its value can move in either direction depending on the underlying pathology. Reduced DLCO has three distinct mechanisms. Surface area loss occurs in emphysema, where destroyed alveolar walls leave less total membrane available for gas exchange. Barrier thickening occurs in interstitial lung disease and fibrosis, where the diffusion pathway itself becomes physically longer and harder to cross. Vascular drop occurs in pulmonary embolism, pulmonary hypertension, and anemia, where reduced pulmonary capillary blood volume or reduced available hemoglobin limits total gas uptake. Increased DLCO, a less commonly tested but important pattern, occurs through two distinct mechanisms. Capillary volume increases in non-acute asthma and polycythemia, simply providing more blood volume available to bind the test gas. Alveolar hemoglobin increases in pulmonary hemorrhage syndromes, such as Goodpasture syndrome and granulomatosis with polyangiitis, where free hemoglobin leaking directly into the alveolar space avidly and falsely binds the test gas, artificially elevating the result, an excellent way to distinguish hemorrhagic from purely inflammatory interstitial processes. The chest radiograph translates pathology directly into recognizable anatomical signatures, and 5 classic patterns dominate examination questions. Consolidation appears as homogeneous opacity, and critically, when the airways remain patent within this opacity, it produces air bronchograms, visible branching lucent structures confirming that the underlying disease process is alveolar rather than purely interstitial. Pleural effusion requires at least 200 to 300 milliliters of fluid before becoming visible, producing costophrenic angle blunting and the classic concave meniscus sign as its hallmark radiographic feature. Collapse, or atelectasis, shows increased opacity, volume loss, rib crowding on the affected side, and critically, mediastinal shift toward the affected side, distinguishing it sharply from the volume-adding pathologies. Pneumothorax shows a visible pleural line with complete absence of peripheral lung markings beyond that line, and when under tension, produces shift away from the affected side, a medical emergency. Finally, hilar lymphadenopathy carries a critical laterality distinction. Bilateral hilar lymphadenopathy classically suggests sarcoidosis, while unilateral hilar enlargement should immediately raise concern for malignancy or tuberculosis instead. High-resolution CT provides the most detailed parenchymal slicing available for interstitial lung disease, and distinguishing two major visual patterns is essential. Usual interstitial pneumonia, the pattern underlying idiopathic pulmonary fibrosis, shows a basal predominant subpleural distribution as its key visual marker. The underlying pathology is honeycombing, clustered cystic air spaces with thick walls, combined with traction bronchiectasis, where fibrotic scarring physically pulls open and distorts adjacent airways. The critical clinical note here is that this pattern represents irreversible, established fibrosis, and remarkably, this specific HRCT appearance is now considered diagnostic of idiopathic pulmonary fibrosis without requiring a biopsy in classic, unambiguous cases, an important and updated point reflecting current diagnostic guidelines. Active or acute interstitial processes show a fundamentally different visual marker: hazy, increased attenuation rather than honeycombing. The underlying pathology here is ground glass opacities, distinguished by the fact that underlying pulmonary vessels remain clearly visible through the haze. This pattern is characteristic of hypersensitivity pneumonitis, pneumocystis jirovecii pneumonia, and acute inflammatory processes generally, representing active, often reversible disease rather than the fixed scarring seen in established fibrosis. Identifying the specific microbiological invader behind a respiratory infection relies on 4 complementary investigation strategies. Sputum and acid-fast bacillus testing remains foundational. Sputum gram stain and culture are limited by oropharyngeal contamination, but the AFB smear using Zeal-Nielsen staining provides rapid, valuable screening specifically for tuberculosis. Nucleic acid amplification testing represents a major modern diagnostic advance. GeneXpert MTB-RIF delivers same-day tuberculosis results with simultaneous rifampin resistance detection, now established as the WHO standard for rapid TB diagnosis worldwide. Urinary antigen testing provides rapid, non-invasive confirmation specifically for Streptococcus pneumoniae and Legionella pneumophila, bypassing the fastidious culture requirements that would otherwise delay diagnosis of these organisms by days. Finally, bronchoalveolar lavage, obtained via bronchoscopy, offers detailed cellular analysis. A lymphocyte-predominant fluid points toward hypersensitivity pneumonitis or sarcoidosis. An eosinophil-predominant fluid points toward eosinophilic pneumonia. And a positive silver stain revealing characteristic cup-shaped organisms confirms pneumocystis jirovecii pneumonia, particularly relevant in immunocompromised and HIV-positive patients. 5 systemic blood markers connect respiratory disease to broader autoimmune and genetic processes, and memorizing this index resolves an enormous proportion of immunology respiratory crossover questions. C-ANCA, targeting antiproteinase 3, indicates granulomatosis with polyangiitis, presenting with the classic triad of sinusitis or saddle nose deformity, pulmonary cavities or hemorrhage, and glomerulonephritis. P-ANCA, targeting anti-myeloperoxidase, indicates eosinophilic granulomatosis with polyangiitis, or microscopic polyangiitis, presenting with asthma, eosinophilia, and vasculitis together. Antiglomerular basement membrane antibodies indicate Goodpasture syndrome, the classic pulmonary renal syndrome, combining hemoptysis with glomerulonephritis. Alpha-1 antitrypsin deficiency is a genetic condition, presenting with early-onset emphysema before age 45, a characteristic basal Panasonic distribution pattern, and importantly, unexplained liver disease occurring alongside the lung pathology. Finally, elevated angiotensin-converting enzyme levels support a diagnosis of sarcoidosis, though always alongside characteristic imaging and biopsy findings rather than as a standalone diagnostic test. Together, these 5 markers transform a vague clinical suspicion of systemic autoimmune or genetic disease into a precise laboratory-confirmed diagnosis. When any pleural effusion is identified, Light's criteria provide the definitive method for classifying it as transudate or exudate, and this single classification dramatically narrows the differential diagnosis. Transudative effusions result from systemic factors altering hydrostatic or oncotic pressure, with heart failure as the single most common cause overall, alongside cirrhosis and nephrotic syndrome. Exudative effusions result from local pleural or parenchymal disease, directly increasing capillary permeability, with pneumonia, malignancy, pulmonary embolism, and tuberculosis as the classic causes. An effusion is classified as exudative if it meets any one of 3 criteria: a pleural fluid to serum protein ratio greater than 0.5, a pleural fluid to serum LDH ratio greater than 0.6, or a pleural fluid LDH level exceeding 2/3 of the upper limit of normal serum LDH. Meeting just one of these 3 criteria, even if the other 2 are negative, classifies the effusion as exudative. This elegant 3-part rule, applied at the bedside within minutes of obtaining a fluid sample, immediately separates effusions requiring investigation for local disease from those simply reflecting a systemic process elsewhere in the body. Beyond Light's criteria, 4 additional pleural fluid parameters provide further diagnostic refinement once an exudate has been identified. A pleural fluid pH below 7.2 indicates a complicated parapneumonic effusion, and this specific finding directly dictates management, favoring chest tube drainage over antibiotics alone. A pleural fluid glucose below 60 milligrams per deciliter is classically associated with empyema, tuberculosis, and rheumatoid pleuritis, with rheumatoid pleuritis often showing an especially striking glucose level below 30 milligrams per deciliter. Elevated adenosine deaminase, or ADA, strongly supports a diagnosis of tuberculous pleuritis, and this test is particularly valuable in regions with high tuberculosis prevalence, where it can support a diagnosis well before culture results become available. Finally, a pleural fluid hematocrit greater than 50% of the peripheral blood hematocrit defines a hemothorax, indicating trauma, malignancy, or a procedural complication as the underlying cause. Together, these 4 parameters allow remarkably precise characterization of the pleural microenvironment from a single diagnostic thoracentesis sample. The solitary pulmonary nodule represents one of the most frequently tested integrated diagnostic algorithms in respiratory medicine, beginning with an incidental discovery on chest X-ray or CT. Risk stratification then proceeds across 4 parameters. Size matters significantly. A nodule under 6 millimeters carries very low malignancy risk. Morphology is equally important. A smooth, well-defined border favors a benign process, while a spiculated, irregular border favors malignancy. Growth pattern provides powerful reassurance when present. Stability over 2 full years on serial imaging strongly suggests benignity, since malignant nodules typically demonstrate measurable growth within this timeframe. Patient-level factors including age, smoking history, and any prior malignancy further refine this risk calculation. Based on this combined assessment, low-risk nodules proceed simply to surveillance imaging at defined intervals, while indeterminate or high-risk nodules proceed to PET-CT for metabolic characterization, sometimes followed by biopsy. An important diagnostic caveat worth remembering: PET-CT can produce false negatives specifically in slow-growing tumors, such as carcinoid tumors, meaning a falsely reassuring PET scan should never completely override strong clinical or morphological suspicion of malignancy. Suspected pulmonary embolism follows one of the most rigorously validated diagnostic algorithms in all of clinical medicine, beginning with calculating pre-test probability using either the Wells score or the revised Geneva score. When pretest probability is low, a D-dimer test should be ordered next. A negative D-dimer result effectively excludes pulmonary embolism, owing to its excellent negative predictive value in this low-probability context. A positive D-dimer result, however, requires proceeding to definitive imaging, since D-dimer carries notably poor specificity, becoming falsely elevated in infection, recent surgery, and pregnancy. When pretest probability is moderate or high from the outset, or when D-dimer testing has already returned positive, the pathway proceeds directly to definitive imaging without further intermediate testing. CT pulmonary angiography remains the diagnostic gold standard in most clinical settings, offering direct visualization of intraluminal filling defects within the pulmonary arterial tree. A ventilation perfusion scan is specifically favored in patients with renal impairment, where contrast exposure must be avoided, or in pregnancy, where minimizing radiation exposure to maternal breast tissue is a particular clinical priority. This algorithm exemplifies evidence-based, stepwise clinical reasoning at its most rigorous. The modern diagnostic approach to interstitial lung disease has fundamentally shifted away from reflexive biopsy and toward an integrated four-domain assessment converging on multidisciplinary discussion. History provides detailed occupational and environmental exposure screening, since specific exposures point directly towards specific interstitial diagnoses. Serology provides autoantibody screening, ruling out an underlying connective tissue disease that might be driving an apparently idiopathic interstitial process. Radiology provides pattern recognition through high-resolution CT, distinguishing usual interstitial pneumonia from nonspecific interstitial pneumonia and hypersensitivity pneumonitis based on their distinct visual signatures. Pathology contributes selective surgical lung biopsy, obtained via video-assisted thoracoscopic surgery, but critically, this invasive step is reserved only for cases where the HRCT pattern is atypical or genuinely non-diagnostic, rather than being performed routinely in every case. All four of these domains converge on multidisciplinary discussion, now firmly established as the modern gold standard, combining clinical, radiological, and pathological data together to guide specific immunosuppressive or antifibrotic therapy decisions. This represents the central paradigm shift in interstitial lung disease diagnosis: integration across disciplines, rather than reliance on any single invasive test performed in isolation.